Okay, hello everybody and welcome to today's Health Foundation webinar. My name is Dr. Rammya Mathew. I'm a GP and I'm also a Borough Medical Director in North West London ICS. I've also been a long-standing Q community member. Today we're hosting a panel discussion on the NHS 10-year plan. We're bringing you the leading voices in health policy to explore what the 10-year plan has to say, a blueprint that seeks to transform health, improve outcomes for patients, and also ensure the long-term sustainability of the NHS. The plan lays out an ambitious vision for the next decade. Our aim today is to unpack what it has to say, both for patients, professionals, and for policymakers alike. We're going to be looking at what the levers are for change, but also what some of the gaps are, what some of the unanswered questions are. Before I introduce our panelists today, I'm just going to cover a few bits of housekeeping. The event today is being recorded, and the recording will be available on the Health Foundation website within 24 hours. This is meant to be an interactive webinar, which means that you can take part in a Q&A discussion. That means that you can submit your questions via the Q&A box at the bottom of your screen. So please do use this. You can also upvote questions which you feel you want us to take up in the panel discussion at the end. I'm now going to introduce our speakers today. So firstly, we have Phoebe Dunn, who is Senior Policy Fellow at the Health Foundation. Phoebe is going to be talking to us about the levers for change within the 10-year plan. Then we've got Dr. Luisa Pettigrew, GP and Senior Policy Fellow at the Health Foundation. Luisa is going to be exploring the shift from hospital to community with a particular focus on neighbourhood health. Then we've got Alex Kennedy, Policy and Engagement Manager from the Healthy Lives team. Alex is going to be looking at the plan's ambitions around the movement from sickness to prevention. And finally, last but not least, we've got Tom Hardie, Senior Improvement Fellow at the Health Foundation, who's going to be exploring the shift from analogue to digital. On that note, I'm now going to hand over to Phoebe to start us off. Thank you.
Thanks, Rammya, and hello, everyone. Just going to wait for I think we've got some slides to come up. So a lot of the analysis so far has focused on the plan's overall ambitions, policies, and whether they can be delivered. I'm going to talk a bit about a recent piece we wrote where we identified some of the kind of policy ideas that seem to guide proposals within the plan, talk a little bit about some of the evidence about their potential impact, and then see what it all kind of adds up to. So next slide, please. So here are the 5 policy ideas I'm going to cover, and let's kick off with the first one. So next slide, please. So first up is the return of more market-like mechanisms in the NHS, so similar to those adopted by New Labour in the 2000s. Competition and collaboration coexist in the NHS alongside other approaches, but the dial is really shifting away from collaboration as the organising principle for managing the health service. Commissioning is back. Providers are going to be removed from ICBs, and ICBs will be asked to focus on strategic commissioning instead. For providers, more power and autonomy via this revamped foundation trust model and other measures to kind of stimulate competition between them. So the logic here seems to be that competition, freedom for providers, financial incentives, clearer rules are needed to improve quality and value for money. Evidence tells us the kind of previous forms of NHS commissioning have often struggled to have an impact on patient care and outcomes. The same is true when you look internationally at evidence on kind of strategic purchasing. And it's kind of hard to see what will be different this time around, particularly when you look at the proposals in the broader context. New Labour's market reforms in the 2000s did coincide with big improvements in care, but the main ingredient there was probably, likely to be this big cash injection, which will not be available this time around. So the second kind of linked idea is around transparency and choice. So proposals here centre on assessing organisations, ranking them in league tables, and then publishing that information. So making performance more open to public scrutiny and enabling people to choose between providers. So publishing information about healthcare performance can open up, interrogation of performance and improvements in care, but there's less good evidence on the impact of these single kind of aggregate ratings and league tables. They can also have negative effects like gaming, and they're really complex to design in a good way. Evidence on previous policies to boost patient choice in the NHS is also mixed. And I think one of the main points under this sort of idea is that patient choice is already embedded in policy today, and there's a raft of information out there on offer to the public. So it's not clear maybe what the new government will offer in practice. Patients might become more aware of their right to choose and have better information to make their decisions, but more choice won't be enough to kind of deliver some of the benefits that government is hoping for in this area. So next slide, please. So alongside competition and choice, collaboration isn't out of fashion completely. The plan talks a lot about better integration of local services to improve care, prevent ill health, reduce hospital admissions. The big proposal is obviously around neighbourhood health services and centres. Luisa is going to come back to this, so I'm not going to go into any detail here. And then alongside that, some NHS trusts will also become integrated health organisations. So seemingly kind of drawing some inspiration from the US, and now have responsibility for managing all health services in their area. And the kind of integrated care ideas build on a long history of similar initiatives. And more integrated care might be better for patients, but I think it's unlikely to save money or radically reduce hospital use. The evidence is quite mixed there. Any benefits take time to deliver, and a real mix of ingredients needs to make it happen. And it's really not clear how some of these more integrated services in the community are meant to work without reform and investment of adult social care, which is obviously kind of not forthcoming at the moment. A fourth idea then is giving people more hands-on control of their health and care. So again, a kind of range of measures here around better care planning, greater use of personal health budgets, giving people access to a single personal patient record, and this renewed emphasis on patient feedback. Some of these measures would be good for patients and others potentially would not. But many of the proposals in the plan are existing policy or have been planned, subject to planned expansions before. And at the same time, alongside these measures, other proposals and changes could erode patient voice. So thinking, for example, about scrapping health watch organisations, bringing their functions into the NHS means patients losing that institutionally independent voice. And NHS organisations, we know, have a mixed record of listening to patients and the public. The next slide, please, and the final kind of idea running through the plan, which is about a more devolved NHS. So concepts here about earned autonomy, a smaller centre, fewer targets, and kind of links to the broader devolution agenda that government is pursuing. And throughout its history, national policymakers have kind of embraced this rhetoric on devolution and localism, but actually central grip appears to have kind of strengthened in recent decades, not diminished. Policies have often been limited in practice, or leaders have struggled to make use of those freedoms. And internationally, again, there's kind of not such great evidence on the impact of decentralisation in health. Other changes in the plan, again, kind of likely increase central oversight, thinking about bringing NHS England under closer ministerial control, top-down performance management, which will continue around these high-profile hospital targets. So the question here, I think, is really, will policymakers be able to let go this time around? Will it happen? Will things change? And final slide, please. So what's it all add up to? I mean, the plan's based on a mix of ideas about how the health service might improve. Many of them still need to be fleshed out, and others probably won't deliver the benefits that policymakers expect. But I think a bigger issue is probably that these ideas conflict and can pull the health system in different directions. So thinking about focus on competition and choice, but also suggesting these large integrated providers are going to run services across whole areas of the country. When we look back at previous plans, they're often the starting point for reform, not the final word, and the detail often comes later. Changes in direction are really common, but what's needed now is a kind of clearer guiding theory for how change might happen, and guidance that helps leaders navigate some of these trade-offs between objectives and different approaches. So I'm going to finish there, I think, and hand over to Luisa, or hand back to you, Rammya.
Thanks, Phoebe. But yeah, I think what stands out is the scale of transformation that is being proposed, and that decentralisation, but perhaps also the fact that there is benefit space, particularly for some of the changes around integrated health, whether that would actually save money in the system. So interesting to hear. Yeah, great. I will move on to Luisa then. I think we're all waiting to hear about neighbourhood health.
Thanks, Rammya. I think your sound's gone a little bit. It sounds like you're underwater, but I heard that. Thanks very much. So good afternoon, everybody. My name is Luisa Pettigrew. I'm a GP and I've recently joined the Health Foundation as Senior Policy Fellow. So my job today is to take you through a bit of the good, the bad and the ugly of the 10-year plan and think about what next with regards to the focus on hospital to community. So next slide, please. So, and just to say that to do this, I'm drawing somewhat on my experience as a GP. I was previously also a primary care network clinical director, and I've come from a background in research. So I'm drawing on the evidence to try and sort of identify these aspects of the plan. So chapter 2 of the plan hinges on the development of neighbourhood health services delivered by multidisciplinary teams as the main vehicle for moving care closer to home. The plan also proposes neighbourhood health centres, proposes a one-stop shop in every community, open 6 days a week, 12 hours a day, and offering co-located NHS, local authority and voluntary sector services. And to incentivise the development of these services, there's a proposal for 2 new contracts, one covering around 50,000 patients or population that aims to build on the existing work around primary care networks, and a larger one which aims to cover several neighbourhoods of a population around 250,000. And this latter contract will be open up to GP federations, but it will also be open potentially to NHS trusts, acute trusts or community trusts. And these larger contracts are aiming to provide support for back office, support data analytics, quality improvement, estates management, and so on. Amongst other things, and there's another contract, there's a third contract, the Integrated Health Organisation. So that's proposed to offer the very best, quote unquote, foundation trusts to take on the whole budget for an entire population for pretty much all the services that population needs. And the aim is that there'll be a few pilots, but over the long run that these will, quote unquote, become the norm. Amongst other things that the plan flags is to bring back the family doctor, end the 8 AM scramble, reform dentistry, NHS dentistry, and expand the role of the community pharmacy. So next slide, please. Thanks. So the good. So there's several positive aspects to highlight in the plan. Firstly, it makes a very strong case for change. It draws attention to the pressures facing the NHS and the need to shift care closer to home. The plan's ambitious, potentially overly so, but it sets a vision for the direction of travel. And there's a welcome focus on the patient and obviously delivering in the community, which aligns with long-standing aspirations to move away from hospital-centric models. The plan also builds on recent publications, including neighbourhood health guidelines and the standardising community health services guidance. What you can see in the diagram are the 6 core components, the proposed 6 core components for neighbourhood health. And progress has already been made in many of these areas across the country. I think also importantly, the plan recognises inequities in health and care and signals a forthcoming review of the GP funding formula, aiming to address disparities in resource allocation. And it also recognises that one size does not fit all. And NHS leaders have described a tight, loose, tight approach, being tight on the aims, loose on the mechanisms to achieve them, and then tight again on measuring outcomes. And this approach should or aims to enable local systems to innovate while being aligned with national goals. So next slide, please. Thank you. So after the good comes the ugly. So one of the most noticeable criticisms of the plan has been that it lacks a delivery strategy and a clear theory of change. So while it's got a really ambitious vision, there's little explanation as to how the proposed interventions will lead to the outcomes it promises. It also fails to engage really quite well. It doesn't engage meaningfully in the lessons from similar initiatives in the past. Phoebe made a comment regarding previous initiatives. For example, the integrated care pioneers, the Vanguard sites, and the associated MCP and PACS contracts around the mid-2010s, which were explored but never fully adopted or scaled up. And looking further back, the Darzi polyclinics from the late 2000s, which didn't survive the coalition government after 2010. Likewise, there's legacies around private finance initiatives in NHS estates, which have left trusts with financial burdens and inflexible structures. These are not addressed, but are proposed as a potential solution to build new neighbourhood health centres. Financially, also, the plan rests with pretty optimistic accounting assumptions. The 2.8% annual funding uplift announced in the spending review is below historical averages, as Phoebe has also said, and is likely insufficient to support the scale of transformation being proposed. And in addition, in the absence of additional money, the plan suggests, or the government has suggested, reducing hospital deficits to be reinvested in primary care. So they propose a £2.2 billion earmarked for deprived areas, but given that many hospitals have remained in deficit for years, it's really unclear how these savings will actually be realised. I think also compounding these challenges, the fact that ICBs are going, significant change. They've got to deliver on 50% cost reductions. They're now shrinking. There used to be 42. The plan is potentially to be as few as 11. And meanwhile, NHS England is being phased out. So these organisations, despite their imperfections, played a really important role in policy, development and support and contract oversight. So the removal is somewhat disruptive, and it raises serious questions really about who will drive and sustain the shift from hospital to community-based care. There's also some pretty shaky assumptions and selective evidence used. So, for example, it claims that there'll be an extra 2,600 full-time equivalent GPs due to ambient voice technology saving GPs so much time. And frankly, it seems pretty naive to think that savings will translate into more patients being seen, given the pressures in general practice and the fact that most GPs just regularly work overtime, and we're actually hemorrhaging GPs in the workforce. So it might help job satisfaction, aid retention at best. And then more broadly, there seems to be an assumption that integration and multidisciplinary teams will yield quick returns on investment. And while these approaches definitely have been shown to improve satisfaction and can improve access, the evidence around the costs and outcomes is mixed. And in fact, increasing access may add greater pressures on services that are already fairly stretched. The other thing is to highlight that it talks about a neighbourhood health centre for every community, but it only commits to 40 to 50 over the term of the next Parliament, with quite rightly so priorities given to areas of greater socioeconomic deprivation. But longer term, it only has an ambition for about 200 by 2035. So if we consider community to be 30 to 50,000 patients, as PCNs have been developed on these sort of areas, then actually we'll be about 1,000 neighbourhood health centres short if the aim was really to provide one for every community. And finally, this is a pet peeve for myself and Jake, my colleague, that the government seems to have trouble counting GPs. The plan and previous press releases repeatedly count head counts rather than full-time equivalent, and draw attention to the number of GPs recruited through the new additional roles reimbursement scheme, but without giving acknowledgement to the fact that GPs are also leaving, so they don't provide sort of an overall net figure. So it kind of, it results in a misleading picture. So we need some consistency and transparency around how we're actually counting GPs. Next slide, please. And then the potentially ugly, not definitely ugly, but potentially. the first is that the plan clearly opens the door to vertical integration. That's where hospitals take on the running of general practices and community services potentially, as well as horizontal integration, whereby maybe general practice and community providers merge together or work more closely together. Now, vertical integration has, the inspiration comes from the US. However, evidence about the use of vertical integration in the UK is much more limited. In 2023, less than 1% of GP practices were part of an NHS trust, and most trusts in that capacity are sort of caretaking for practices that are in difficulties, and there's only a small number of sites that have actually got sort of scaled up general practice within trusts as part of vertical integration. And again, the evidence shows modest benefits, potentially sort of 2% reduction in A&E attendances, 3% reduction in emergency admissions, but no change overall in inpatient activity or patient experience. And the team of researchers from Birmingham, Cambridge and Rand Europe who led this research, the main research on this in the UK, concluded just a few years ago that there was no compelling case for widespread rollout of vertical integration at that point in time. So, although economies of scale may appear and there might be better coordination between services and there might be more career progression opportunities for staff, it can also mean the loss of autonomy in primary care, loss of responsiveness, increased bureaucracy, increasing distance from patients as well, potentially. There's also the risk that, if primary care is absorbed into secondary care, that without adequate guardrails around financing, the primary care is expected then to absorb some of the deficits from hospitals as well. The other potentially ugly thing is white elephants. That was a nickname given to Darzi Centre in the late 2000s. They were viewed potentially as costly, duplicating services, and they're viewed as a threat by GPs. So if neighbourhood health centres are not carefully planned and integrated with existing GP practices, they may become the new white elephants. Related to this, the reference to the GP contract was notably nearly absent, and for many GPs and the BMA, the threat of vertical absorption and polyclinic type models may be unwelcome, and it may contract negotiations may become ugly at that point in time. But I just want to flag that things are different somewhat than they were when this was last attempted. Practices have now grown in size. They're much more accustomed to work at larger scale, work across multiple sites. Primary care networks have pushed practices to work together and diversify the workforce. So GPs actually now only represent around 16% of GP practice staff, and GP partners are half of those. So half of GPs now are salaried doctors. So, with the promise of maybe better career progression, job security, less risk, particularly if you're a partner that you've got to face unlimited liability, there may be less resistant this time round to integration and neighbourhood health centres potentially. The other thing I just want to flag is that in the London target operating model around neighbourhood health care, there was a proposal for primary care networks footprint to be aligned to match those of the proposed neighbourhoods. While I understand the logic of it, I think there's a real risk there, and it might be counterproductive because over the past 5 years, practices have worked hard to establish those relationships. So trying to sort of unpick those may not be a good thing to do if that happens nationwide. I also want to highlight that despite an effort to want to integrate services, there's a risk of fragmenting care. So, through initiatives like risk stratification, population segmentation, the expansion of multidisciplinary teams, all these things could, although well-intentioned, undermine continuity of care, which is associated with better patient satisfaction, better productivity, and better quality outcomes. And then obviously, finally, there's the risk of distraction from care from all these reorganisations that are taking place. So next slide, please, which is the last main slide. So what next? Tomorrow, I think, is the last day to apply for the Neighbourhood Implementation Programme. This is going to support 42 sites to be selected to be the first sort of neighbourhood sites. As the programme progresses, we really need clarity on the 2 proposed provider contracts, because there's not clarity around how they'll work together, how they interact, how they fit in with the existing GP contract, with community service contracts, how will they be managed, what funding will be offered, and how will success be measured. So there's just a real lack of clarity around that just now. And then the other thing that we need to understand better, community services, while we understand quite well general practice and secondary care, community services remain opaque, so we need better data. So anyway, so we need more data on community services to help sort of measure the left shift and deliver on the neighbourhood health agenda. And then amidst all these changes, it's really important not to forget that the public's #1 priority currently is GP access. So alongside, improving GP access, you need to remember about continuity of care retention. You need to maintain workforce morale and goodwill during all these changes. You need to realise that these changes take time and significant upfront resources to deliver on change. And I think there needs to be a heavy dose of realism around how quickly these things can happen. If you look back, we've already been trying for about a decade to get to this point. So we probably have a journey of at least another decade ahead if we want to be realistic about things. And so last slide has just got some resources which you can refer to in your own time once you get a copy of the presentation. So that's it from me.
Thanks so much, Louisa. Can I check, can you hear me okay now? No.
It's odd, yeah. I don't know whether you might need some headphones.
Let's go straight to Alex then, and I'll try and sort out my sound.
Thanks. I'll just wait for the slides to come up. So hi. Yeah, talking here, I'm Alex Kennedy and talking about the shift from sickness to prevention within the 10-year plan and sort of more widely across government policy. Yes, by making one of the 3 shifts, this shift from sickness to prevention, the 10-year plan for health did recognise that it's not enough simply to treat ill health, but that really government needs to be thinking in terms of improving health and improving tackling the inequalities in our health in order to both secure the long-term sustainability of health and social care services, but also more generally thinking about the impact that has on the economy and, of course, on all of us as individuals. That can be seen sort of rhetorically, both through that shift, but also in the framing of the plan as being a plan for health rather than as a plan for NHS. And that's carrying on a theme that you could also see really clearly stated within the Labour Health Mission going back to 2023, and that the election was fought on, was very much presenting the challenges that the country has around health as being much wider than just about fixing the NHS, as important and central as that has been. So next slide, please. So just, I'm sure this will be familiar to lots of you, but the reasons why this is something that we should be concerned about. This chart looks at the trend in improvements in life expectancy, and you can see how about 15 years ago, the trend, we fell off the long-term trend of improvements in life expectancy. Clearly, there is a point at which just drawing a straightforward line isn't going to be true anymore. There is a limit to how long we can live biologically, but actually we're sort of not there yet. And you can see that from the fact that Britain has also lagged behind competitor countries. So that in the year 2000, the UK was the 20th out of the 38 OECD countries for female period life expectancy. By 2022, we'd fallen to 26th place. So sort of not keeping up with other countries in terms of the improvements in health, in life expectancy. And next slide, please. And as well as being a concern around life expectancy, there was also serious concerns around morbidity too. So looking at this is the sort of chart that lots of people might expect from our demographics and the knowledge of the pressures being put on the healthcare service from an aging population. So this is the growth in the number of people living with a major condition, a major health condition, or well, major illness. So it might be a combination of health conditions. In the year 2040, but this is the chart for the 10% of the least deprived areas, and you get this growth primarily in the retired population, in older people. But if we look at the next slide, it really shows very clearly the health inequalities, because this is the slide for the 10% most deprived areas. And you can see here a huge growth in the number of people right the way down into their 40s of people who are living with major illness within working age. And you can actually see here that, most of, 80% of the increase major illness in the working age population is going to be in the half of areas which are the most deprived. So these are some of the reasons that this is so critical to look at. Next slide, please. So I think our concern is that although, as I mentioned, there's a really strong messaging around how this is a health plan and sickness to prevention. There's a wide-ranging cross-government health mission, but that ultimately, when you look into the details, it was more of a plan for the NHS in England rather than a plan for a healthy nation or addressing health inequalities writ large. And fundamentally, that sort of wider vision of the health mission is a bit missing in action. So the positives are that there is a recommitment, at least, to the ambition of closing the gap in healthy life expectancy between the best and worst performing regions, and some further commitments around developing a suite of indicators to track progress, recognizing that healthy life expectancy ambition is both very broad and also very long term. What there's a lack of, and the next slide, is the sort of specific and coordinated action that's needed to tackle the wider determinants of health. So there is, of course, there are, while there are some of this agenda does sit with the NHS, so there are plans, so there are policies within the 10-year plan around genomic testing or increasing access to vaccines. The greatest gains really for prevention are to be had through action both on the individual risk factors, whether that's unhealthy food or alcohol or smoking, and wider determinants of health from housing to employment and poverty. And although that's challenging, it does require a cross-government approach, but we know from all the sort of rhetoric around this that that's something the government understands. So we were really hoping to see a bit more detail within the 10-year plan, showing the actions that will get there. So public health is a lot wider than just the public health budgets that sit with directors of public health and local authorities. But even on that slightly narrower metric, you can see that public spending on public health allocations has dropped very considerably. And despite a recent injection of some more funding, it's nowhere near where it was a decade ago. And that's something that the 10-year plan hasn't set out a pathway to fix. On to the next slide, please. Moving across to the policies set out within the 10-year plan on risk factors. So there's a bit of a mixed picture, I'd say. The most progress is probably to be seen in the action on smoking. A lot of that was in reality in train previously, so not mainly new announcements within the 10-year plan. Probably a bit more of a mixed picture on obesity. I think it remains to be seen how impactful the proposals are. The proposal will be on increasing the expectations on large food retailers in terms of providing healthy food. But there are certainly gaps around, how is poverty going to be reduced, and how can regulation be used to improve the food environment for people. And I think, moving on to the next slide, the biggest gap of all, really, and the greatest worry is on alcohol, and really, apart from some quite minor announcements on labelling, a real lack of this sort of ambitious action that's needed on that. On the wider determinants of health, there is quite a lot of mention within the 10-year plan of the role that other departments, beyond DHSC and beyond healthcare more generally, can play in promoting health and tackling health inequalities. So there's mention of physical activity in the Department for Culture and Media and Sport, and what it can do to promote that, air pollution and the role of transport, quite a lot on employment quality, quite a bit on young people's mental health, and the work that the Department for Education is planning on doing on that. But across all of those areas, I think it's fair to say there's very little in terms of new policies, certainly very little in terms of new funding. And what's really lacking across the top of all of that is the coordination and oversight and clarity about what the how each of those policies individually will come together to form more than the sum of its parts. And I think that kind of lack of coherence can maybe be seen from the fact that for all of the different areas that are mentioned, actually there's not a section in there on poverty, which arguably is probably the greatest, sort of most impactful wider determinant of all. Perhaps that's because we're still waiting for the cross-government strategy on poverty, but nevertheless, it does feel like quite a gap and a bit indicative of the risk that this isn't going to be the kind of coordinated action, or at least it's not yet going to be the kind of coordinated action that we know is needed. So moving on to the next and final slide, I think this is setting out really what we're hoping to see and what we think, as it wasn't in the 10-year plan. I think this really should be the priority for the next stage of thinking through what sickness to prevention really means. I think we need a health inequality strategy that really sets out how to reach that long-term ambition around improving healthy life expectancy, around closing the gap in healthy life expectancy. I mean, for starters, that ambition doesn't yet have an end date given to it. So it's not really a target in the sense that there's no clarity at all when it would be achieved by. And I think we'd also argue that beneath any broad target like that, you really do need to start to set out in some detail what role different policies and ambitions and targets will play in getting you towards such a long-term ambition as that. What role are different departments going to play? What role is going to be played at different levels of the system? So it's really interesting that within the devolution package that's been set out, there is a plan for strategic authorities to have a health duty, but without the clarity from government about which elements central government's driving on, which elements are being expected to be delivered by regional government or by local government, it's hard for the system to know which bits each level should be focusing on. And across all of that, I think there's an important role that can be played, that should be played in independent monitoring of that progress. I think one of the concerning things about the Health Mission Board that's been set up to sort of steer the agenda so far is that there's a real lack of transparency in terms of membership or what's being done by those new sort of bodies that are meant to be steering this programme. But actually, I think monitoring and accountability is going to be really important in terms of making sure that we are on track for delivering what is inevitably a complex and challenging and ambitious set of policies that will be needed. But ultimately, by the government's own admission, the scale of improvement in health and health inequalities that's needed can only be delivered through quite complex cross-government action and working across all levels of government as well. Thank you.
Thanks, Alex. That's really helpful. I think it was positive to see in the 10-year plan that ambition around reducing the gap in healthy life expectancy. But as you say, I think that focus on the wider determinants of health and how that cross-government working is going to come to fruition might be lacking. Thank you. So let's go on to Tom now, who's going to talk us through analog to digital. I think digital featured probably the most heavily in the 10-year plan. I had colleagues who did a search of the document and said that I think that was the most frequent word within the document. So I'm sure you've got a lot to say.
Yeah, thanks so much, Rammya. I just wait for the slides to come up, but yeah, completely agree. You know, the 10-year plan really does bet big on technology, and so I'm going to spend the next 10 minutes or so just kind of taking us through what those big kind of commitments are, how realistic they are, and what we need to get right if we are to achieve any of those commitments. So looking at what the plan says, it aims to transform the NHS and entirely reimagine how the NHS provides care with science and technology, really key to this transformation. The plan seeks to make the NHS digital by default, with a beefed up and expanded NHS app becoming the main front door of communication with the NHS, and also giving patients access to a single patient record, which will then be accessible through the NHS app as well. The plan sets out what it calls 5 big bets for technology to drive healthcare reform. And these are data, artificial intelligence, genomics, wearables, and robotics. And some of the main commitments that the plan makes under these 5 categories of technology include things like developing a new £600 million health data research service, making the NHS the most AI-enabled health system in the world, sequencing the genome of 100,000 newborn children, and making wearables standard in preventative, chronic, and post-acute care. The plan is super ambitious on technology and innovation. It aims to position the UK as a global leader in tech and innovation. It recognises that we have some way to go from taking technologies and innovations that have some evidence behind them to adopting them at scales, and it recognises the challenges that we need to overcome to accelerate the adoption and spread of proven technology. And I think it's fair to say that it has really high expectations for the impact that technology will have on patient care and also on workforce productivity. So many of you will have seen that there's a target within the plan of 2% productivity gains year on year, and digitisation is seen within the plan as a key enabler for achieving these productivity gains. We'll move to the next slide, please. So from my perspective, I think the plan contains some commendable ambitions, but it is really ambitious for technology and wants to drive a lot of these changes using technology and innovation. Some of the commendable ambitions in there for me include things like the single patient record and the NHS app, which if done well, could better support people to access information, communicate with the NHS and manage their health. There's a good emphasis on improving data quality, access and utility. They're obviously long-standing goals, but the plan sees the single patient record and the new health data research service as some important ways to achieve those goals. And this could then help provide actionable insights about patients on an individual level, but also populations, support research, as well as support technology development, including artificial intelligence. It's good to see a commitment to use technology to support staff and make their work more sustainable and more satisfying. In particular, there's an emphasis on cutting through the burden of admin, which we know is a really big issue for healthcare professionals. There's a welcome emphasis on co-designing new uses of technology with patients and staff, and tailoring things like the content of the NHS app to our different communities, which are going to be really important because there's no kind of one size fits all for technology. There's a commitment to develop a strategic roadmap for AI. So that's something that we've been calling for at the foundation, and we think will be critical if we're to harness the potential of AI in a responsible way. The plan acknowledges that there's further to go to get the basic tech infrastructure right, so things like computer systems and electronic health records, and we think that's an important acknowledgement to make. There's also a welcome emphasis on reducing friction for innovation and for innovators, including private sector innovators. So it's good to see plans to make it easier for innovators to work with the NHS, and there are commitments around streamlining regulatory processes and the development of what they're calling innovation passports, which will make it easier to take innovations that have evidence behind them to implement in other sites across the country. And then lastly, it's good to see a desire to improve funding mechanisms and procurement approaches. So, for example, through multi-year budgets and contracts, as well as national funding for NICE approved innovations and improved procurement frameworks. And these could all be steps in the right direction if they're delivered in an effective way. If we move to the next slide, please. But while there are some commendable ambitions for technology in the plan, it's really hard to ignore that this is more of a techno-optimistic than techno-realistic vision for technology. So to begin with, tech is very much focused and framed as a silver bullet, particularly artificial intelligence. Technology is positioned as the hero that's going to come in and save the day. And we need to caution against that and be realistic about what technology can achieve. The level of ambition here is immense, as Rammya pointed out. It's weaved into the plan throughout. There are lots of commitments, and these are going to require a vast array of things to go right or to be fixed. And it arguably doesn't acknowledge the technical and socio-cultural challenges for delivery, for instance, around the cultural and behavioural challenges or changes that will be needed, and some of the technical challenges that will need to be addressed for this to be delivered. So, for example, joining up hitherto siloed sources of data that we've been kind of trying to address for many, many years. We talked earlier about limited evidence. I think some of the proposals have quite limited evidence. So, for example, personalised prevention. This is much more theoretical than proven at the moment. And I think there's a lot more work to do to evaluate artificial intelligence and understand what impact it can have in different domains of healthcare. I think there are also some big assumptions about what improved digital information and access can bring about. There's a sort of notion here that if patients and the public can access information and services digitally, then this will automatically lead to improved outcomes. But we know that information alone isn't enough to bring about behaviour change, because it doesn't address the wider physical and socioeconomic factors that influence individual decision making, and kind of chimes with what Alex was saying earlier. Then in terms of access, better access to appointment requests could create further demand that can't be met. So we need to kind of test and drill down into those assumptions. While there are references to digital inclusion, for example, supporting digital literacy or providing devices to those people that can't afford them, the plan doesn't set out how tech can actively reduce health inequalities, which I think is a missed opportunity. Of course, acknowledging the wider kind of socioeconomic factors that influence our health that are beyond the scope of the NHS. I still think there was a good opportunity missed there to talk about how tech can help tackle health inequalities. Similarly, there's nothing on how tech and data can help shift to a lower carbon healthcare system and support the NHS's journey to net zero. And there's nothing acknowledging the footprint that technology can have and how that can be mitigated. There's also not enough recognition, again, chiming with what other people have said, of the lessons from past efforts to achieve some of these goals, in particular efforts to digitize the NHS, put in place digital records and so on. We've tried before and failed to create a single patient record. So why is it going to be different this time? We'll move to the next slide, please. So how do we turn the tech vision into reality? Given the level of ambition, this is going to require huge effort and change. So from our perspective, the first kind of stage to getting this right involves doing the right planning and the right groundwork, without which we're not going to be able to make any progress on this in a timely way. So I think firstly, this means being realistic about what technology can achieve and when, and so this includes the impact on productivity. In research that we conducted at the Health Foundation, where we asked clinical staff how they would spend time freed up by technology, our respondents allocated 27% of that time to direct patient care. This was then followed by using that time for reducing overtime, doing quality improvement work, taking care of admin, which are all really important activities, but are obviously different to direct patient care, which needs to be thought through. The plan also focuses a lot on the technology itself. The next stage needs to describe how services will change. This means setting out how care should be redesigned, what tech-enabled pathways should look like, and how healthcare work and professional roles could evolve for the better. I think there's also an important job to do to think through how digital first will shift demand. For example, the potential volume of communication through the app with healthcare professionals, thinking that through and how that's going to be dealt with. Likewise, the increase in requests for appointments. How will these scenarios be dealt with, and how will we meet that demand? Then there's also something about getting the basics right. This is going to be critical, and there is further to go. So our recent research on the cost of digitizing the NHS showed that half of the kind of close to 15 billion required to fully digitize the NHS is needed to complete the building of the foundation. So that's things like electronic health records, sorting out connectivity and Wi-Fi, hardware, corporate IT, cybersecurity, and so on. And I think there really needs to be a greater focus on supporting organizations that have lower levels of digital maturity to ensure that they don't get left behind. If we move on to the next and final slide, so kind of second series of things I think that are needed in that kind of planning and groundwork stage includes things like buy-in from staff. At the end of the day, if they're not on board, this plan won't happen. The good news from our research is that the majority of staff that we've surveyed are supportive, generally supportive about technology and AI in healthcare. So they are receptive, but plans for transformation need to be co-produced. They need to be cognizant of the context staff are working in, and they need to show how tech will help them and improve their working conditions. By the same token, public support and involvement are also important. Our survey work shows that some groups, for example, young people and women, and also people in socioeconomic groups, D&E, are actually less supportive of technology. And so we need to understand and address those concerns. And I think while it's really good to see a commitment in the plan for co-designing technology with patients, we know from our research that some socioeconomic groups are actually less inclined to get involved in tech development, even if they're paid. So we need to come up with creative ways to engage and involve them. And just a couple more points to make before I finish. Implementation and optimization is hard work. It takes time, effort, and resources, and has historically not had enough focus and support. So we need to build the capability and capacity for this. We also need more evaluation. I pointed out some of the areas of technology that are big in the plan that need more evidence. I mean, we need to know what works, what doesn't, and why. And our research indicates that more support is needed for robust real-world evaluation of tech and innovation. And then finally, there's a question around the capacity of key actors and making sure that they have the capacity that they need. So, for example, in the plan, NICE is going to be expected to undertake a bigger role in appraising technologies, which is a really tall order when you consider the volume of health technologies and the complexity of evaluating them. So they're going to need to develop their capacity. And then despite plans for clustering, I think the plan raises questions about how ICBs will do the things that they're expected to do in the plan. So, for example, shaping markets, engaging with tech companies and fostering innovation in their areas. How are they going to do that with reduced operating budgets? So we need to think about how that capacity can be earmarked. So in summary, I think on technology, the level of ambition is massive. There's a vast array of commitments. And so prioritizing and getting the planning and groundwork right is going to be really critical. And I'll hand back to you, Rammya. Thank you.
Yeah, thanks so much, Tom. It does feel like we're going through a bit of a technological revolution in society as a whole, and I feel like the 10-year plan has really taken that and run with it. But I think you're right to throw caution to the wind and particularly point out those draw attention to digital exclusion as well. Okay, so we've got a bit of time for Q&A, and I've been having a look at the questions that are coming through. So the first question I'd like to draw on is from Andrew Fenton, and I'm going to put this to Phoebe, if that's okay. The question is, the 10-year plan is happening alongside big organisational changes in the NHS, the merger of NHSC and Department of Health, cuts to and mergers of ICBs, closure of CSUs. What are the likely consequences of these changes? Will they enable or hamper delivery of the ambitions in the 10-year plan?
Yeah, thanks for the question. There's just a huge number of changes now underway on there. I mean, I think I'd just point to the kind of massive disruption for local areas over the next few years. Lots of time and energy of senior leaders now spent on restructuring and merging and working through the complex list of things that entails, rather than kind of working to improve care or making progress on some of these headline priorities. And that will be really particularly acute for some areas who are going through, a really big set of changes, particularly when you add in local government changes and the patient safety stuff. And I guess it's just hard to see how some of the ICB stuff in particular helps them deliver on this vision of strategic commissioning. We know in the past commissioning's been kind of hampered by these asymmetries between providers and commissioners. So what does this kind of do to address those? Commissioners also been on a constant treadmill of reform and reorganisation since 1991. Evidence from those suggests that reorganisation has kind of delivered little benefit. So yeah, I think it will be a really challenging context to try and make progress on some of these 10-year plan ambitions.
Thanks, Phoebe. Yeah, I agree. I think it's a huge challenge, isn't it, at the scale of change and then trying to do reorganisation at the same time. So next question I've got is for Luisa, and this is a question from Stephen Black. He says, access to GPs is a major concern for patients. Does the plan set out serious proposals? This includes things like structures, systems, or new bodies that are likely to improve access and or address the 8 AM rush.
Yeah, that's a good question, because access is a top priority. So it doesn't specifically set significant things out. So there's a few ways to approach this. I think one of the things that you can avoid the 8 AM rush by going to other services. So there's definitely a focus on community pharmacy delivering more clinical care. And I think that's already happening in many areas. I think if you look at what's happened with the GP contract this year, from October, there's going to be an expectation that GPs need to be able to respond to all queries. You can't turn somebody away, so you need to be able to respond to online phone queries or in-person queries. So, and there's a bit of extra money related to the contract this year, although admittedly a lot of it's being absorbed through national insurance contributions and so on, and the cost of living increases. I think the other thing that's changing is that there's going to be a patient charter due to come out, not necessarily going to fix the access problem, but it might give patients both a sense of what they should be expecting, which may hold practices to greater account in terms of what they're expected to deliver, but also it may also give patients a steer in terms of their responsibility around self-care and so on. I think maybe some of these sort of digital solutions are also meant to help patients support self-care, but I don't think they're tried and tested yet. So I think we're probably a long way off beyond that. And I think the other thing is that there's been this sort of agenda around modern general practice, and a lot of that has hinged around improving online access for patients, so asynchronous online consultations, and improving how practices triage requests and so on. So I think there's a series of things that are attempting to improve patient access, and there has been some movement in terms of patient satisfaction. It's gone up ever so slightly between this year and last year in the GPPS, and also in an ONS patient satisfaction survey. It seems to be going up. So it may be the case that we are seeing some movement in terms of improving access, but I think we're still a long way off, and GPs are under a huge amount of pressure still to deliver.
Great. So it sounds like there's some inkling of a positive change, but a long, long way to go. Can I ask you a follow-up question, Luisa? So this is on integrated care. You touched on this because you said that integrated care has been an ambition in previous health plans, but it hasn't actually ever really truly been delivered before. Do you think there's anything different in this plan that is going to make that this time different?
So I probably wouldn't say there's something in the plan itself, in the sense that, you know, we lack details of the delivery plan and on the contract and so on. I guess what I said in my presentation, that we're a slightly different place and now than say 10, 15 years ago. The NHS is probably under greater pressure. You know, the plan says reform or die. So there's a bit more sort of impetus to change. Like I said, the context has changed. We've got more salary doctors. There's less partners. Partners are feeling increasingly under pressure. There's the stuff around the unlimited liability. There's newly qualified GPs not finding employment. So all these factors may lead to potentially less resistance to integration if larger organisations can provide stability, career progression, but balance that also with, you know, clinicians' autonomy, responsiveness, being close to patients, and dealing, you know, supporting patient satisfaction. Because I think one of the big things is that the evidence does not suggest that larger practices or organisations improve patient satisfaction, the opposite. So if organisations are going to be large, they have to take a lot of care to make sure they've got good access, continuity of care where it's needed, and they meet patients' needs and address patient satisfaction.
Thanks, Louisa. That's helpful. I've got a question now for Alex. So this is around health inequalities. And a participant has said that actually the plans are based on regional disparities in healthy life expectancy, which is around 6 to 7 years. But in certain areas, for example, Blackpool, that gap is much wider, as wide as 18 years. So is the target ambitious enough? And should we be asking for more, particularly in these areas of high deprivation where there's such an impact on healthy life expectancy?
Yeah, thank you. So yeah, it's certainly very much the case that you have that even though there are quite substantial gaps between regions, there are even bigger gaps between different local authorities on healthy life expectancy and on other metrics like life expectancy too. So in that sense, just having a target, and as I said, at the moment there's no end date, so it's not really a target on healthy life expectancy by region isn't really enough. You know, if you follow that to its logical conclusion, only focused on that, then you'd end up saying to, you know, quite big areas of the country, well, you don't really need to worry about improving healthy life expectancy, even though within those areas there will definitely be places which have far below average healthy life expectancy. I guess sort of zooming out a little bit, I think it's, you know, looking at it from the other end, actually it's quite an ambitious target in the sense that if you look at the long-term trend on healthy life expectancy, both overall and in terms of inequalities, it's been remarkably static. So to close that gap would really involve changing that sort of trend, that chart, quite a lot. So in that sense, it is quite ambitious. I think I'd ask a slightly different question, which is whether a national sort of by closing the regional gap healthy life expectancy target is enough on its own. And basically, I don't think so. I think you both need some of those, you need to be measuring on smaller sort of geographic scale, but I think you also need a broader set of measures, some interim targets, because even if it's successful, then a strategy is only going to start shifting measures like healthy life expectancy and life expectancy over maybe a decade, and you really want to be able to see that you're making progress sooner than that. And to do that, you need to break it down into, well, what do we think are the things that would lead to better healthy life expectancy, and then and then start measuring those and being really clear which policies you're delivering would lead to the changes in those, which levels of government you're expecting to deliver on those policies, and sort of thinking it through in that kind of systematic way. And so I think that's what we really need to see as part of a health inequality strategy, is that level of thinking which kind of goes beyond that one big target and actually brings in that next level of detail and accountability, really.
Yeah, thanks, Alex. I think you're right there that we need a bit more granularity beyond healthy life expectancy. I think it'll be interesting to see what the metrics are that they're proposing around health inequalities. It might help address that. Tom, I've got a follow-up question for you on reducing inequalities. So this is an anonymous question. Is there a risk that the big emphasis on digital health could actually increase health inequalities? And if so, what needs to happen to mitigate or prevent this?
Yeah, I mean, it's a great question. I think there's definitely a risk, and kind of addressing that depends on how digital transformation is done and what kind of interventions are brought in. I think there are some potentially promising things in the plan on this. So, for example, really making the NHS app inclusive, developing content in different languages, making it accessible for people with visual impairment, for example. And like I said before, I think there was a good emphasis on the need to improve digital literacy and health literacy so that people using technology can get the benefits from it. But I mean, as is the case with pretty much all of the commitments in the plan, there's no detail underneath. So, how do you actually do that? And it's going to be a big challenge. And I think that, unless we design with inclusion as a sort of central tenet, and we include a variety of our kind of end users and communities, then there is a real risk that some people will not benefit. And I know the plan talks about how by pivoting to digital will free up in-person resources for people that can't or don't want to use technology. I think that makes a big assumption that this is going to be the case in practice. So I think that we need to make technologies accessible as possible, and we need to think through at a kind of national level. And it's good to see a cross-government strategy on tackling digital exclusion, but the backdrop is pretty stark, isn't it? I mean, the Good Things Foundation find that around 8.5 million lack basic digital skills, and 1/5 of people that they've surveyed feel like they're being left behind by technology. And we also know that a lot of technology is often designed for the mainstream and not for people that are at risk of not being included or at risk of experiencing health inequalities. So I think we need to kind of bring tackling health inequalities to the fore in the way that it did during COVID, and I feel like that's been lost to an extent in the plan, and there's not enough in there on the kind of the tech commitments, so how this is actually going to be done. But I think that that there's quite a lot of work to do to get this right.
Yeah, thanks, Tom. That's really interesting. I do want to fit in this question because I'm particularly intrigued to hear the answer. Maybe I'll ask Phoebe to pick this up. It's a question from Stella O'Brien. She says, the plan partly relies on patients acting more like consumers, but do patients have the knowledge, information, or inclination to do that? And does the plan set out any proposals to support patients to extend their self-management and consumer skills in healthcare?
Great question. I mean, this is not my area of expertise. I have to go back, but I think it probably doesn't go into the detail of some of how some of these shifts are going, how some of these policies are going to kind of hit the ground and make change this time. We've had policies around some of these things for many years and many previous attempts, personal health budgets, care planning. We've tried to expand those. We know there's some good evidence for them. So I guess, oh gosh, sorry, the light's just gone out where I'm sitting. So no, I don't think it, the detail isn't in there on how these things are going to actually transform care and put power into patients' hands this time. I think that there's a lot to be done on the kind of cultural shifts around some of this. I'll leave it there. I know we're just about out of time.
Okay, I'm going to ask you all a quick fire question just to wrap up. So obviously we've had the plan published, but we're still awaiting the delivery chapter. And if there's one thing that you want to see in the delivery chapter, what would that be? So I'm just going to go around. I'll give you a bit of a break, Phoebe. Maybe start with Luisa.
Thanks, Rammya. So I guess we need urgently contract details, funding mechanisms, outcome measures, particularly around neighbourhoods, and a bit more clarity about, there's lots of things that have got neighbourhood to the name floating around, centres, services, guidelines, the contracts. We need some clarity around how this all fits together, please.
Okay, fab. Alex?
Yeah, so I think it's that whole bringing things together, that on its own, it's probably not just adding a few more specific details to what's already been announced, but a bit more of a vision for what's going to be needed on addressing the wider determinants of health.
Tom?
Yeah, thanks. I mean, I think we've covered a couple of times the lack of implementation plans here, but really the success of the tech ambitions, and to be honest, any of the ambitions in the plan will come down to the NHS's capacity and capability to implement change. And doing that well requires resources, skills, and headspace, which are really constrained at the moment. So I think what I'd like to see is a real focus on implementation and the development of a package of support to help providers rapidly adopt and optimize technology.
Yeah, finally come back to Phoebe.
Yeah, I mean, I think I'd be looking for some support for leaders to help them navigate some of these tensions and conflicting objectives. There's a great question about, the elective waiting times pledge versus these longer term shifts on hospital to community, which have been tried for so long and haven't happened. So how can the delivery chapter kind of help leaders make progress on those objectives when it's been so hard in the past? One broader thing, if I can sneak it in the end, is just social care. It's so hard to see how some of these plans are going to happen without reform and investment in adult social care services. So I know that's outside the scope of the plan, but I just think it's so central to a lot of this and looks a little bit slow at the moment.
Great, thank you so much for all of your thoughts. Yeah, I think we've had a really fantastic sort of hour and a quarter discussion and Q&A. And I really want to thank the speakers for all their analysis of the 10-year plan. I think there's so much in there, but you've really drawn out all the key points and shared the evidence and the insights with us. And thank you to everyone who's attended today in the audience as well. Just a reminder that this has been recorded and the recording will be uploaded to the Health Foundation website, and a link will be sent to you as well. So do share it with colleagues who might be interested. Thanks again. Have a good afternoon.